A very good morning to respected teachers, my fellow batchmates, and anyone else present today. Today, roll numbers 136 to 151 are going to be presenting a seminar on the support, clinical significance, and anatomy of the uterus, with special emphasis on the uterine prolapse and its anatomical correlations under obstetrics and gynecology. And I, Yudhishthir Atri, take great honor in welcoming you all. Today we'll be taking a deep dive into intriguing clinical cases rather than drowning in monotonous slides for the next hour or so. It is important that we understand the embryological development and anatomy of the uterus so we can separate simple physiology from conditions like ectopic pregnancy and uterine prolapse. The aim of this presentation is to integrate basic anatomy of the uterus with its obstetric and gynecological significance. That's all from my side. I now invite Aditya Verma to take over.
Good afternoon, everyone. Myself Aditya Verma. My roll number is 144. Today I'm about to present the case of.
ऊपर रखा है उसमें.
Today I am about to present the case of uterine prolapse, a clinical case in which the patient name is.
उल्टा. ठीक है.
The patient name is Phool Kumar Yadav. She is a 63-year-old woman. The past obstetric history includes 6 gravida and 6 parity. Now, what is gravida? Gravida refers to the number of times a woman has been pregnant, while the parity refers to the number of birth to the fetus she has given. Chief complaint includes mass protruding outside the vagina for 3 years. History of present illness are the patient present with a large mass permanently outside the vagina. She reports difficulty walking, sitting, and performing daily activities. There is associated vaginal discharge, occasional bleeding, and foul odor. She complains of urinary retention with occasional overflow, incontinence, chronic constipation, recurrent UTI infections. She also reports ulceration over the protruding mass, causing pain and discomfort. The past history includes all home vaginal deliveries, no medical care sought due to social reasons. Examination findings are complete uterine prolapse, also known as procedentia, while with cervix and uterus entirely outside the vaginal introitus. Decubitus ulcer present over the exposed tissue. Now, decubitus means pressure due to the ulcer generated on an epidermal tissue on the peripheral due to the pressures and abrasions. This is also associated with cystocele and rectocele. Cystocele means the prolapse of the bladder, while rectocele means the bulging of the rectum tissue into the vagina. Now I call my friend. Now I'll call Ayush Vishwakarma for the uterus anatomy.
What is cystocele?
Cystocele means, ma'am, the prolapse of the bladder, urinary bladder.
Where?
Through the vaginal opening.
It comes out completely.
Along with yes, ma'am. It also comes out completely in the stage 4 cases.
Cystocele is the bulging of the urinary bladder in anterior wall of vagina. Okay. So if you are saying grade 4, it comes out rare but possible.
Okay.
Good morning everyone, myself Ayush Vishwakarma, roll number 146, and today I will be discussing about the location, layers and function of the uterus. So, the location, the uterus is located inside the pelvic cavity. It is located dorsal to the urinary bladder and ventral to the rectum. That is, it is situated in between the urinary bladder and the rectum. Now, talking about the parts of the uterus is divided into the fundus. This is the upper part is known as the fundus. The body, this part is known as the body, and the inner cavity, that is known as the uterine cavity. Now, this is a diagram representing the location of the urinary bladder. This is the uterus, this is the urinary bladder, and this is the rectum. Now, talking about the layers of the body of the uterus. The body of the uterus is mainly divided into 3 layers: the perimetrium, the myometrium, and the endometrium. The perimetrium is made up of thin layer of connective tissue and mesothelium, that is the serosal layer. that covers the entire fundus and the body of the uterus except at the lateral part where the broad ligament is present. Now talking about the myometrium, we all know that the word myo means muscle. So it is therefore the myometrium is nothing but the thick bundle of muscle fibers that are held together by connective tissue. This layer is further divided into three layers: the inner circular layer, outer longitudinal layer, and a middle reticular layer. The reticular layer is rich in blood supply, and it is important. It prevents excess bleeding during delivery. Now the third innermost layer is the endometrium. We all know about the endometrium, as there is no submucous layer in the endometrium. The endometrium is opposed to the muscle coat. The endometrium mainly consists of the lamina propria and the surface epithelium. The surface epithelium is made up of single layer of ciliated columnar epithelium, whereas the lamina propria consists of glands, vessels, and nerves. Now talking about the glands are tubular and are lined by mucus secreting non-ciliated columnar epithelium. The endometrium is further divided into two layers. That is, the innermost layer is known as the stratum functionalis, and the little outer layer is known as the stratum basalis. The stratum functionalis consists of the spiral arteries, and it is important and undergoes cyclic changes during menstruation. Whereas the outer layer is known as stratum basalis, it consists of straight arteries, and it helps in the growth of the stratum functionalis. This is the diagram representing the same as this is the fundus. This is the outer layer, middle layer, and the inner layer. This is the uterine cavity. Now talking about the functions of the uterus, we all know that the uterus is important for fetal development or the gestation. It is also important for the implantation and nourishment of the blastula. It is important for the menstruation, labor, delivery, postpartum delivery, that is the things that occur after the delivery of the child. And the last one, that is the support for pelvic structure, which will be explained in the further slides. Now I call Tonishka to continue with the axis of the uterus. Thank you.
Good morning, everyone. Hi, my name is Tonishka, roll number 141, and my topic is axis of uterus. Okay, here. The position of the uterus in the pelvis is maintained by two angles formed by an axis passing through the uterus, cervix, and vagina. The two angles which are of main importance is the angle of anteversion and the angle of anteflexion. Anti means forward, version means to turn, so forward bending. So the angle of anteversion is the angle between the long axis of the body of the uterus and the axis of the vagina, and it is 90 degrees. This means that the cervix is in front of, or it tilted forward over the vagina, and the significance of this is that the uterus is supported on the urinary bladder, and this is the proper position of it for its function. The factors maintaining this anteversion of the uterus is the forward pull by the round ligaments on the uterine fundus and the backward pull of the cervix by the uterosacral ligaments. And the clinical significance of anteversion is that in retroversion, if the uterus is retroverted, see, if this is the uterus and this is the anteversion of it, if it is, this is the stable position over the urinary bladder. If it is retroverted, it means that the mass is now aligning with the vaginal axis, which means there is a bulky mass and it can descend down due to gravity, and this is one of the implicated factors for uterine prolapse. So this is the diagram. This is the long axis. This is the axis of the vagina. So moving on. Now the angle of anteflexion. The angle of anteflexion. It is the angle between the axis of the cervix and the axis of the uterus. It is 125 degrees, and it is. And this, according to this, it means that the body of the uterus is tilted forward and it is above the cervix. So it is tilted forward, and this configuration is very stable, and it allows for the proper drainage of menstrual blood, and it is optimal for implantation. And the clinical importance, a uterus that is retroflexed or retroverted may have symptoms of dysmenorrhea, which is pain during menstruation, dyspareunia, which is pain during intercourse, or they might even have fertility issues. So this is anti-flexion. And the normal position of the uterus is in the median plane. Slight tilt is there in
Can you listen
people.
to her, sir?
There is some variation. But if there is too much pressure by the sigmoid colon on the left side, there will be a dextrorotation of the fundus because the sigmoid colon is on the left side, it will put pressure. So the fundus of the uterus will move towards the right side. And if the fundus moves to the right side, the cervix will move to the left side because it will begin like that. So, like if I can draw it. So if this is the uterus, if we consider this is the cervix and this is the vagina. If this moves, okay, if we consider this side to be right and this as left, if this moves to the right, this will move to the left. Okay, thank you. I think that's mine. Yeah, now I'll call Tanishka to continue.
Good afternoon everyone, my name is Tanishka Garkal and my roll number is 137, and today I will be talking about the relations of uterus, including its visceral relations, peritoneal relations, and we will also talk about the peritoneal recess. So first, fundus of uterus, it lies above the openings of fallopian tubes as the enteral cornea of fundus. So as you can see here in the diagram, fundus of uterus, it lies above the fallopian tube. Talking about its anterior relation, uterus anteriorly is related to the urinary bladder.
Use the progressive.
So here uterus, it is anteriorly related to urinary bladder. Posteriorly, it is related to the rectum, mostly parts of small intestine, which includes ileum and sigmoids of colon.
The pouch.
In the pouch. Anteriorly, it forms the uterovesical, because like the uterus, it is anteriorly covered with the peritoneum, and this anteriorly it reflects onto urinary bladder, forming the uterovesicular pouch. Posteriorly, it reflects onto rectum, forming the rectouterine pouch. Then laterally broad ligaments of uterus, they extend on the other side and include uterine arteries, veins, ureters, and lymphatics. Like here we can reflect this in this diagram. Laterally it has broad ligaments of uterus. Also superolaterally it is connected with ovary, fallopian tube, and the round ligaments of uterus. Now talking about the peritoneal relations. The uterus is mostly covered by the peritoneum anteriorly, except in a few regions which are also known as the non-peritoneal surfaces. Peritoneum it covers anterior surface of the body, but excluding the cervix and peritoneum, it covers entire posterior surface of the body and supravaginal part of cervix, and it reflects onto rectum, forming the rectouterine pouch. Rectouterine pouch is also known as Douglas pouch, and it is the lowermost point of peritoneal cavity in females. Laterally, peritoneum extends to from broad ligaments, which are the double layer fold of peritoneum, and they extend from sides of uterus to lateral wall. And the non-peritoneal surface include the anterior surface of cervix, the lateral aspects of cervix, and uterus where broad ligaments are attached, which they are not completely peritoneal. Now talking about the peritoneal recess, the two vesico-uterine pouch, which is present anteriorly between the bladder and uterus. So you can reflect this here between the uterus and urinary bladder. Here will be the vesico-uterine pouch. Its clinical significance is in C-section axis, then endometriosis, and the retroverted uterus, which is like the uterus, it goes backward towards the spine rather than coming towards the urinary bladder anteriorly. And then we have rectouterine pouch, which is the pouch of Douglas. which is present posteriorly between
Pouch of Douglas.
Douglas. Douglas, which is present posteriorly between rectum and uterus, and it is the common fluid collection site as in rupture, ectopic pregnancy, and pelvic abscess drainage. Which pelvic abscess drainage is basically a removal of unwanted fluid from the pelvis. Thank you. Now I call Varsha to continue further.
Good afternoon, everyone. My name is Varsha Kamble, roll number 145. Now I will be talking about the gross anatomy of the cervix and vagina. As we know that cervix is an important component of female reproductive system, which play key role in menstruation, childbirth, and fertility. Now talking about cervix is a lower cylindrical part of the uterus, which is about 2.5 centimeter long and slightly wider in the middle than at either end, which is less mobile than the body of the uterus because of the supporting structure and ligament. At birth, cervix is twice in a length than the body of the uterus, which is in the ratio of 2:1. But after the puberty, it elongates and becomes longer than cervix, which is in the ratio of 1:2. Then this lower part of cervix, it projects into the vagina and is divided into two parts. Supravaginal part, which lies above the vagina, and vaginal part, which projects into the vagina. Then comes to relation. Anteriorly, this supravaginal part is related to posterior surface of bladder, and vaginal surface is related to this anterior fornix of vagina. Then posteriorly, it is related to the rectouterine pouch, and posterior part of cervix is related to posterior fornix of vagina. Then laterally, supravaginal part is related to ureter and the uterine vessel, and vaginal part is related to fornices of vagina. Then comes to cervical canal, which is a cavity of cervix. It's fusiform in shape and it communicates with uterine cavity above through internal os and below with cavity through the external os. Canal is extend from the before backwards as it has anterior and posterior walls, and these walls show mucosal folds which resembles the branches of tree, which is called as arbor vitae uteri, and these folds are interlocked with each other and closes the canal. In nulliparous woman, this external os is small and circular, and in multiparous, it bounded by anterior and posterior lips, and it which are contact with posterior wall of vagina, and it gives slit-like appearance. Then comes to vagina, which is long fibromuscular tube that extend backward in front of rectum and anal canal, which extend from cervix to vestibule, lined by stratified squamous non-keratinized epithelium, which has two muscular layers, outer longitudinal and inner circular layer, lining by adventitious tissue. It has no any gland, and there are functions that receptacle for the penis during coitus, outlet for menstrual flow, passageway for childbirth. Then comes to fornices. This interior part of the upper end of vagina is in form of circular that surrounds the cervix, and it becomes progressively deeper and divide into four parts. Anterior fornix, which lies in front of the cervix and its shallowest. Posterior fornix is lies behind the cervix and it deepest. Lateral fornices, which lies on the each side of the cervix. Thank you. Now I would like to call Mayuri to continue.
Good afternoon everyone, myself Mayuri Temburde, roll number 139, and today I will present the seminar on support of uterus. It is interesting to know that why this support is necessary, as uterus undergo extensive changes during the reproductive period, especially during the pregnancy and the menstruation. Because of these changes, the uterus needs some supports, and that support is provided by the musculature structure and some ligaments. And that support will prevent the uterus from sagging. The supports are of two types, the primary support and the secondary support. The primary support of uterus is mainly muscular, and which includes pelvic diaphragm, perineal body, and the distal urethral sphincter mechanism. Let's see about the pelvic diaphragm. Pelvic diaphragm forms the floor of pelvis, and it supports the pelvic viscera and resists rise in intra-abdominal pressure. And it forms the supporting slings for vagina. As you can see here in the diagram, that pubovaginalis, puborectalis and the pubococcygeus proper can form the pubococcygeus, and that pubococcygeus part get inserted into the perineal body and which try to fix it. During the parturition, the pubococcygeus torn leading to the prolapse of uterus. Second one is the perineal body. Perineal body is the fibromuscular node formed by the attachment of the 10 muscles. That perineal body in female is present between the vagina and the anus, and in case of male is present between the urethra and the anus. And the 10 muscles which are responsible for the formation of the perineal body or which get attached to the perineal body are 2 superficial transversus ani, 2 deep transversus ani, 2 pubococcygeus, part of the levator ani, and 2 bulbous spongiosus, the 1 sphincter ani externus muscle and the 1 longitudinal muscle of the anal canal. As you can see here, this is the perineal body and these muscles get attached to the perineal body. Then third one is the distal urethral sphincter mechanism. In this, the urogenital diaphragm, which is not exist within the urethra as it is seen in the urethral wall. And in addition to this, the compressor urethrae and the sphincter urethrae vaginalis get inserted into the vagina and support the uterus indirectly. Then now we will see the secondary support of the uterus, which includes the true ligament and the false ligament. As you can see here in the diagram, this is the pubocervical ligament, transverse cervical ligament and the uterosacral ligament. Uterosacral ligament is present between the cervix and the sacrum, and main function of the uterosacral ligament is to maintain the retroversion of the cervix. And this is the pubocervical ligament, this is the transverse cervical.
Retroversion or anteversion?
Anti-retroversion.
Anti-retroversion. What is that? Okay, continue.
And this is the transverse cervical ligament which extends from the cervix to the lateral pelvic wall. And the third one ligament is the round ligament. That round ligament is extend from the uterine cornu up to the labia majora via inguinal canal. And main function of the round ligament is to maintain the anteversion of the uterus. The second ligament is the false ligament, which is the peritoneal fold, and which includes the broad ligament, vesicouterine fold, rectouterine fold, and the ovarian ligament. In broad ligament, which is the double-layered peritoneum, which hold uterus, fallopian tube, and the ovaries. Then the vesicouterine fold is present between the urinary bladder and the uterus. And third one is the rectouterine fold, which is present between the uterus and the rectum, which is also called as the pouch of Douglas. Then fourth one is the ovarian ligament, which connect the ovary to the uterus. Now I would like to call Tanmay.
Good afternoon everyone. Myself Tanmay Shete, roll number 138, and today I am going to present about the arterial supply, venous drainage, nerve supply and clinical anatomy of the uterus. Let's begin with the arterial blood supply. The uterus is a highly vascular organ which is supplied mainly by the two uterine arteries with additional support from the two ovarian arteries. The uterine artery is a major branch arising from the anterior division of the internal iliac artery. As you can see in the diagram, the uterine artery doesn't just supply the uterus, it also supplies vagina, middle two-thirds of the uterine tube, ovary, ureter, and structures within the broad ligament. Uterus has living ligatures. The myometrium, the muscular layer of the uterus, contains oblique muscle fibers which constrict and retract following the childbirth. The constriction of these vessels prevent excessive blood loss, acting as natural internal ligatures. Moving on to the clinical anatomy, we must understand the spatial relationship of the uterine artery and the ureter. As you can see in the diagram, the uterine artery passes from the lateral to the medial side, above and in front of the ureter, before entering upwards into the layers of the broad ligament, which is why the surgical procedures involving the ureter and uterine artery must involve careful attention due to their close proximity and potential for the injury. Now let's understand how the blood leaves the uterus. The venous drainage largely mirrors the arterial supply. The veins of the uterus form complex venous plexuses around the lateral border of the uterus. These plexuses eventually drain into the internal iliac veins through the uterine and vaginal veins. Now finally we come to the nerve supply of the uterus. The uterus is richly innervated by both sympathetic and parasympathetic nerve fibers. The sympathetic fibers are derived from the T12 to L2 spinal segments. The sympathetic fibers cause uterine contraction and vasoconstriction. The parasympathetic fibers are derived from the S2 and S2 to S4 spinal segments. These fibers act to inhibit the uterine muscles and cause vasodilation. However, it is important to note that even though autonomic control is present, the uterine activities are mostly controlled by the hormonal control rather than direct neural output. And we can see the tortuous course of the uterine vessels in this diagram. Thank you, and now I would like to call Vaishnavi to continue further.
Good afternoon everyone, this is Vaishnavi Bandal and today I am going to be covering uterine prolapse in this seminar. So what is uterine prolapse? Uterus prolapse falling down of an organ. So uterine prolapse is herniation of uterus into or beyond vagina. So as Mayuri before me brilliantly explained the pelvic supports, the basic pelvic supports which support the uterus, which hold the uterus in its place, they weaken. And due to the weakening of those supports, the uterus descends down. I have included a short clip. So as you can see, this is the uterus and it is descending down. It is interesting to note that in this case, the urinary bladder is also descending down with it. And as the video progresses, we can see different phases of the uterine prolapse which will be discussed later. So there's a system, TNMC's 3-level system, which is worldwide accepted for the causes of uterine prolapse. So level 1, so it is divided into 3 levels, level 1, level 2, level 3. In level 1, we have carino-uterosacral ligament complex. In level 2, we have arcus tendinous fascia pelvis and the fascia covering the levator ani muscle. And in level 3, we include the perineal body and the urogenital diaphragm. Now, according to the system, the weakening of these 3 levels, any of these 3 levels or all of these 3 levels leads to uterine prolapse. There are 2 types of uterine prolapse, congenital uterine prolapse and uterovaginal uterine prolapse. Congenital uterine prolapse is also known as nulliparous prolapse because it is present in nulliparous women. So of course, it is going to be because it is congenital. It is not associated with cystocele and it is due to the congenital weakening of the supports. The uterovaginal prolapse is more commoner and the cystocele occurs first and it is followed by the traction effect on cervix causing the retroversion of uterus. Now we will be seeing the degrees of uterine prolapse. Now we have 3 degrees and the first degree is more commonly seen in the middle-aged women, whereas the second and third degree is seen in older women. In the first degree uterine prolapse, the patient is usually asymptomatic and it means that the cervix has started to descend into the vagina, but it hasn't reached the introitus. In the second degree uterine prolapse, the patient may feel sensation that something is falling down in the pelvis or a dragging pain in the back, which means the cervix has reached the introitus. In the third degree uterine prolapse, a visible bulge is outside the vagina and the patient has difficulty in walking, sitting, performing daily activities, and urinary retention may be there. So these are the 3 degrees of uterine prolapse. As you can see, there's the decubitus ulcer, which was mentioned by Aditya in the first case, and in the third degree uterine prolapse, the uterus has descended down to the introitus. Now, these are the stages of uterine prolapse. There are 5 stages. In the stage 0, the uterus is in its normal position. In stage 1, it has started to descend down. This stage is usually asymptomatic. In stage 2, the cervix has descended into the vagina. In stage 3, it has reached the introitus, and in stage 4, it has come out of the vaginal opening. This is the same diagram but in a different view. So in stage 1, the patient is usually asymptomatic. In stage 3, a dragging pain or a feeling of something falling down in pelvis may be present. In stage 3 and stage 4, we can see a visible bulge, and in stage 4, medical attention is required because the patient is not able to perform daily activities. Now, symptoms, before, I have mentioned the symptoms before too, but in the gist, the symptoms may be feeling of something falling down, pain in the back, dyspareunia, which means pain during sexual intercourse. Urinary symptoms may be there, retention, feeling of incomplete emptying, similarly bowel retention, straining during defecation, and excessive bite or blood discharge. Risk factors includes older age. It is said that the risk doubles every decade the woman lives, and race, white and Hispanic women are more susceptible to this condition. Family history, increased body mass index, obese women are more susceptible, higher parity, vaginal deliveries, and constipation. Now, talking about treatment, the conservative treatment includes pelvic floor muscle training. Now, pelvic floor muscle training doesn't necessarily treat the uterine prolapse, but higher percentage of women have reported that it treats the symptoms. Vaginal pessaries, this is a pessary. Vaginal pessaries are the only non-surgical option available for the treatment of uterine prolapse. It is a soft silicone device which is removable, and the fitting of pessaries is very important. The medical professional has to ensure that the pessaries are fitted well. So the process is that we should ensure that the patient's bladder and bowel are empty, and a finger should be swept. A finger can be swept between the walls of vagina and the pessary. The goal is to fit the largest pessary, which does not cause any discomfort, and the patient is asked to walk around to ensure that the pessary is retained. Now we move to the surgical treatment. Surgical treatment is more often used for the treatment of uterine prolapse. We have 2 types: hysterectomy, which is the removal of uterus. It can be done. Abdominal hysterectomy and vaginal hysterectomy can be done. But the hysterectomy, first of all, the uterus is removed, so the fertility is lost. And again, the hysterectomy does not ensure that there is the natural course of prolapse. The other pelvic organs do not prolapse, right? So usually after hysterectomy, a mesh is inserted to support the other pelvic organs. If the patient is to preserve her fertility, we use uterine preserving surgeries, and as the sacrohysteropexy, in which a mesh is inserted and it is secured to the sacrum. Sacrospinous hysteropexy, in which the sacrospinous ligament is secured to the vagina and the cervix. The uterosacral ligament, similarly, the uterosacral ligament is strengthened. In the Manchester Fothergill operation, same procedure is used as the uterosacral ligament hysteropexy, but cervical elongation takes place, so cervix is amputated here. And then pectopexy is a new method in which we use mesh to support the pelvic organs. Now we will be discussing briefly the investigations of uterine pathologies. We have imaging techniques and direct visualization. Imaging techniques include ultrasound and MRI. Ultrasound and MRI are used to detect polyps, abnormal endometrial bleeding, And ultrasound is more commonly used because it is more cost effective, it has lesser side effects. Now moving on to direct visualization, we have hysteroscopy. In hysteroscopy, a camera is introduced to the uterus via the vaginal opening, and carbon dioxide is used to relax the uterus for a better view, and it is used to diagnose conditions like fibroids, polyps. It also guides endometrial biopsy. Now biopsy, as we all know what biopsy is, so a piece of tissue is taken and then it is examined in the laboratory, and it is used to identify the endometrial hyperplasia or cancer. It is used in infertility evaluation, and it is also used to check for uterine infections. So that concludes my portion, and I would like to call Vaishnavi for presenting an interesting case.
Good afternoon everyone, myself Vaishnavi Gade, roll number 143, and today I'll be presenting a clinical case titled as the acute abdomen mystery, a life-threatening case which hides behind a very common complaint, that is the abdominal pain. So we have a 26-year-old female coming to the emergency department with right lower abdomen pain, right shoulder pain and vaginal bleeding. She is 7 weeks pregnant and has a history of pelvic inflammatory diseases. She looks pale, sweaty and visible distress, and she has increased pulse rate and low blood pressure on arrival. On examining the abdomen, there is marked tenderness in the right iliac fossa, and on vaginal examination there is cervical motion tenderness, which is called as the Candelier sign. So intense pain is elicited when cervix is moved, and this is a very important hallmark sign for pelvic inflammatory diseases. But it can also be a diagnostic for ectopic pregnancy or appendicitis. Secondly, as the patient is having a previous history of pelvic inflammatory diseases, so she has a strong chance of abnormal implantation. Because bacteria in cases of like gonorrhea and chlamydiasis, so infection and inflammation that spreads from vagina to uterus and then to the fallopian tube. So this damages the cilia of fallopian tube, and so there is tube obstruction and embryo is not able to implant in uterus. Now let's see the anatomical correlation of the case. So in normal pregnancy, as the fertilization takes place in the fallopian tube and the zygote moves to the uterus for implantation, but in case of ectopic pregnancy, the embryo grows in size in the fallopian tube and it stretches beyond its capacity and it ruptures, so leading to massive internal bleeding, and the blood is collected in pouch of Douglas, which is located in the lowermost peritoneal cavity in the female, as we can see between uterus and the rectum. So did you wonder why Sunita complained of right shoulder pain when the problem lies in the pelvis? It was because the ruptured fallopian tube, the blood moves to the diaphragm and it irritates the phrenic nerve. So as phrenic nerve and supraclavicular nerves, they share the same spinal segment, so we observe referred pain in shoulder. Now moving towards the diagnosis and investigations. So a transvaginal ultrasound, transvaginal ultrasound shows an empty uterus and this right adnexa observed. So basically, adnexa is an anatomical region which includes right ovary, right fallopian tube, and supporting ligaments. And other investigations include blood typing. So blood typing is important in order to know the blood group of female, because as there is massive internal bleeding, so blood transfusion is required. And also RH factor screening is required in case if mother is RH negative and the growing embryo is RH positive. So in order, if there are any antibodies which are developed in female, so for that RH screening is required. And in case of treatment and management, so there is early pregnancy and the embryo is not grown much, so we can give injection of methotrexate, which stops further growing of cell. But in this case, as we observed the USG of Sunita, so she was having empty uterus and her blood was full of abdomen. So she needs immediate emergency laparotomy along with salpingectomy. So in the narrow confines of fallopian tube, the miracle of life can unfortunately become a countdown to clinical emergency. So early diagnosis saves life. Thank you. Now I would like to Yashashree to continue with the topic.
Hello everyone, I'm Yashashree Dabhade, roll number 149. I'll be talking about pre-implantation events. It consists of cleavage, that is a special kind of division that the zygote undergoes after fertilization, morulation, plastulation and zona hatching. Cleavage in embryology refers to the rapid consecutive mitotic divisions of a zygote immediately following the fertilization. Each cell formed here is known as blastome. Cleavage in humans is asynchronous, that is, the blastomeres do not divide simultaneously. Rather, they divide on different rates based on their localized cytoplasmic factors, cell-to-cell signaling, and developmental stage. The cleavage in humans is indeterminate, that is, the fate of blastomeres is not seen. Next is morulation and blastulation. Morula stage is the stage where 8 to 16 cells are present, and this is observed after like 3 to 4 days after fertilization. Whereas blastula stage is 64 to 128 cell stage, which is observed on the 5th day after fertilization. So if you see here, this is the 8 to 16 cell stage, which is morula. This is progress to forming of blastula. If we cut this here, so we'll observe that the blastula consists of zona pellucida, which is retained with the secondary oocyte since ovulation, the trophoblast layer and the inner cell mass. The inner cell mass would lead to formation of embryo, while the trophoblast layer in implantation would differentiate into syncytio and cytotrophoblast. Can you guys guess who this is? Can you guys guess thank you for giving us the consent, Nishant. So, in pre-implantation events, we observe the formation of monozygotic twins or identical twins, which are also known as maternal twins. So, as the blastocyst grows, we observe that the fluid in the blastocele would lead to increased pressure on the zona pellucida, which would later lead to division of the blastocyst into two different identical zygotes. Next is zona hatching. Zona pellucida, as I mentioned, persists with the oocyte since ovulation. So, during implantation, this zona pellucida needs to disappear at the right time so that the blastocyst attaches to the fundus. This process of disappearance of the zona pellucida is known as zona hatching. This is an enzyme-mediated process, and the enzyme here used is trypsin. Thank you. I'd like to call Aditya Verma.
अच्छा, ये आइडेंटिकल ट्विंस दिखाया, फ्रेटर्नल ट्विंस क्यों नहीं दिखाया?
It's during the fertilization. It's not pre-implantation. We have not included fertilization in this PPT. My concern was on pre-implantation events.
Hello everyone, my name is Aditya Verma and I'm about to present the topic of implantation. Implantation is the process of attachment of the blastocyst to the endometrium. It begins after 6 to 7 days of fertilization. The site of usual implantation is the fundus region because the endometrium lining is thick in this region. The significance of implantation in the fundus region is first, the establishment of a successful pregnancy, and second, formation of placenta. Now moving next, the stages of implantation. This includes 3 stages. The very first is apposition, the second is adhesion, and the third one is invasion. Also we can call it as penetration. Now opposition. The blastocysts come in close contact with the endometrium lining and it is a irreversible attachment. This is also weak. Now moving to the second one is adhesion. There are some cell adhesion molecule which attaches the trophoblast layer to the endometrium lining. This is an irreversible attachment. Now the last stage is invasion. The trophoblast invades endometrium and finally differentiate into cytotrophoblast. The inner side of the trophoblast differentiate into cytotrophoblast and the outer part differentiate into syncytotrophoblast. There are few structural changes after the invasion which are follows as the changes in trophoblast occurs as rapid proliferation of trophoblastic cells, formation of lacunae or spaces. The third is secretion of HCG hormone and finally initiation of placenta formation. The changes in endometrium lining is decidual reaction occurs. Decidual reactions are referred as the reaction in which nutrient providing cells are formed. Endometrial stromal cells enlarge, which convert differentiate into decidual cells. There is increased glycogen storage, lipid content, blood supply. Endometrium becomes thick, vascular, and supportive. Now formation of chronic villi starts. Important for maternal fetal exchange. There are three stages in this chronic villi formation. The very first is primary villi, which only consists of trophoblast only. The further secondary villi formation includes mesoderm, which is provided from the fetus. The tertiary villi finally have fetal blood vessels formed. The other changes during implantation are formation of bilaminar germ disc, development of amniotic cavity, yolk sac, establishment of uteroplacental circulation. Now to continue the topic further ahead, I will call Shreya.
Good morning, I'm Shreya, roll number 140. We have seen implantation events. Now we will see what can go wrong in the events.
इकडे
First is failure of implantation. One of the reasons of failure of implantation is the poor endometrial receptivity. Now what is endometrial receptivity? It is when the endometrium is ready for the implantation. Then the poor endometrial receptivity is due to reasons such as improper hormonal priming, especially progesterone. Then it can due to defective decidualization and thinner abnormal endometrium. Next is abnormal site of implantation, which leads to ectopic pregnancy. Ectopic pregnancy is when the implantation of ovum is outside the uterine cavity. We will see it in detail in the further slides. Defective tropoblastic invasion is the shallow invasion and poor spiral artery remodeling, which leads to high resistant uteroplacental circulation, which causes placental ischemia, poor placental ischemia, oxidative stress, and poor fetal support, which can lead to early pregnancy loss. Clinical problems due to implantation errors are early miscarriage, infertility, abnormal placentation, and bleeding in pregnancy. Now, ectopic pregnancy. As we know, it is the implantation of fertilized ovum outside the uterine cavity. The most common site is fallopian tube. As the embryo grows in the fallopian tube in ectopic pregnancy, it can lead to the rupture of fallopian tube as the tube is thin and lead to blood loss. The patient can go in hypovolemic shock with severe internal bleeding. The types of ectopic pregnancy are interstitial pregnancy with the proportion of 2 to 3%, ischemic pregnancy 12%, the most common is ambulatory pregnancy with 70%, femoral pregnancy, ovarian pregnancy, cervical pregnancy, and abdominal pregnancy. This is a short animation. Now I would like to call Shravani for the next topic.
Good afternoon everyone, myself Shravani Tangai, roll number 136. Imagine the pregnancy that begins normally but yet implant in the wrong place, leading to a life-threatening condition known as ectopic pregnancy. So understanding its causes is very important. So let's begin with the most important cause, that is tubal damage. When normally the fertilized ovum gets transported in the uterus, but when there is a damage to tubal mucosa, there is a loss of cilia, which leads to impaired transport of fertilized ovum. As a result, the fertilized ovum may implant in the uterus may implant in the fallopian tube, which leads to ectopic pregnancy. The location of tubal blockage can give us clues about some causes. First is the proximal blockage, which is near the uterus, mainly due to tubal spasm and cause scarring from inflammatory condition. Next is the mid-segment blockage in the middle of the fallopian tube, caused by tubal ligation and pelvic adhesion. Next we have a distal blockage or in the end of the fallopian tube, mainly due to pelvic inflammatory disease and extensive endometriosis. The diagram showing the pelvic inflammatory disease and endometriosis. Structural abnormalities also plays an important role in causing ectopic pregnancy. It includes congenital defects like tubal hypoplasia, which means underdeveloped fallopian tube, and we have then partial stenosis, means partial narrowing of fallopian tube and elongation of fallopian tube. Another abnormalities includes tubal adhesion and tubal diverticula. Along with the structural abnormalities, hormonal imbalance also plays an important role in causing ectopic pregnancy. Altered level of estrogen and progesterone causes delay in the transport of fertilized ovum, and the ovum get implanted in the fallopian tube. Next is the most important cause is the advanced maternal age, which is especially above the 35 years, which is associated with the impaired tubal mobility and reduced ciliary functions, leading to ectopic pregnancy. Other risk factors include previous ectopic pregnancies, previous tubal surgeries, use of intrauterine contraceptive device such as copper teas, and the last one is the smoking, which affects the ciliary function of the fallopian tube, which impairs the transport. To conclude, ectopic pregnancy mainly occur due to impaired transport of fertilized ovum, which is mainly due to tubal cause. Now, I would like to call Yashraj for the.
Hi friends, myself Yashraj Yadav. Today I am going to talk about diagnosis and treatment part. So, diagnosis, ultrasound, absence of intrauterine pregnancy, serum HCG level, laparoscopy, confirmatory. Coming to the next part. Treatment of ectopic pregnancy, medical management, methotrexate, early unruptured case, surgical management, laparostomy, tube preserved, laparotomy, tube removed. Complications.
स्लाइड्स पहली बार पढ़ रहा है तेरी.
Complications of
साल्पिंग SAL दिख रहा है ना वहाँ पे.
Complications of ectopic pregnancy, tubal rupture.
अरे रीड करो सर्जिकल मैनेजमेंट.
Surgical management, laparostomy. Salpingostomy, salpingectomy. Sorry. The complications of ectopic pregnancy, tubal rupture, hemorrhage, infertility, maternal death if untreated. Now I would like to call my friend Vadora.
एक स्लाइड उसमें भी.
Good afternoon everyone. Myself Vaibhav Chintamanga. Today I am going to present summary. The first is uterine prolapse. This is a descent of uterus due to weakened pelvic support. This is common in clinical condition. Second is anteversion and anteflexion. These are normal position angles which maintaining stability and function of uterus. Third one is layers of uterus. They are perimetrium, myometrium and endometrium. Fourth one is implantation process. There are 3 key steps. First one is apposition, second adhesion and third one is invasion. Fifth one is ectopic pregnancy. These are implantation outside the uterus. Most common site is ampulla of isthmus. Thank you. On behalf of my role mates, I would like to thank you Dr. YGB sir, Dr. Seema ma'am and all faculty of and all faculty of anatomy department, Dr. Jaya ma'am, and all faculty of anatomy department for giving us and thank you for Dr. Ubesh sir for guidance, and special thanks for Yashasri who make your PPT together. Thank you.
बंद करूँ